The COVID-19 pandemic, also known as the coronavirus pandemic, is an ongoing global pandemic of coronavirus disease 2019 caused by severe acute respiratory syndrome coronavirus 2. The novel virus was first identified from an outbreak in Wuhan, China, in December 2019. Attempts to contain failed, allowing the virus to spread to other areas of Asia and later worldwide. The World Health Organization declared the outbreak a public health emergency of international concern on January 30, 2020 and a pandemic on March 11, 2020. As of November 9, 2022, the pandemic had caused more than 633 million cases and 6.6 million confirmed deaths, making it one of the deadliest in history. COVID-19 symptoms range from undetectable to deadly, but most commonly include fever, dry cough, and fatigue. Severe illness is more likely in elderly patients and those with certain underlying medical conditions. COVID-19 transmits when people breathe in air contaminated by droplets and small airborne particles containing the virus. The risk of breathing these in is highest when people are in close proximity, but they can be inhaled over longer distances, particularly indoors. Transmission can also occur if contaminated fluids reach the eyes, nose, or mouth, and, rarely, via contaminated surfaces. Infected persons are typically contagious for 10 days, and can spread the virus even if they do not develop symptoms. Mutations have produced many strains with varying degrees of infectivity and virulence. COVID-19 vaccines have been approved and widely distributed in various countries since December 2020. According to a June 2022 study, COVID-19 vaccines prevented an additional 14.4 to 19.8 million deaths in 185 countries and territories from December 8, 2020 to December 8, 2021. Other recommended preventive measures include social distancing, wearing masks, improving ventilation and air filtration, and quarantining those who have been exposed or are symptomatic. Treatments include novel antiviral drugs and symptom control. Public health mitigation measures include travel restrictions, lockdowns, business restrictions and closures, workplace hazard controls, quarantines, testing systems, and tracing contacts of the infected, which, together with treatments, serve to bring about the control and eventual end of the pandemic. The pandemic has triggered severe social and economic disruption around the world, including the largest global recession since the Great Depression. Widespread supply shortages, including food shortages, were caused by supply chain disruption. Reduced human activity saw an unprecedented pollution decrease. Educational institutions and public areas were partially or fully closed in many jurisdictions, and many events were cancelled or postponed during 2020 and 2021. Misinformation has circulated through social media and mass media, and political tensions have intensified. The pandemic has raised issues of racial and geographic discrimination, health equity, and the balance between public health imperatives and individual rights. Etymology. The pandemic is known by several names. It is sometimes referred to in news media as the coronavirus pandemic despite the existence of other human coronaviruses that have caused epidemics and outbreaks. During the initial outbreak in Wuhan, the virus and disease were commonly referred to as coronavirus, Wuhan coronavirus, the coronavirus outbreak and the Wuhan coronavirus outbreak, with the disease sometimes called Wuhan pneumonia. In January 2020, the WHO recommended 2019 GOV and 2019 GOV acute respiratory disease as interim names for the virus and disease per 2015 international guidelines against using geographical locations, animal species, or groups of people in disease and virus names in part to prevent social stigma. WHO finalized the official names COVID-19 and SARS-CoV-2 on February 11, 2020. Tedros Adhanom Ghebreyesus explained, CO for corona, 6 for virus, D for disease and 19 for when the outbreak was first identified. WHO additionally uses the COVID-19 virus and the virus responsible for COVID-19 in public communications. WHO names variants of concern and variants of interest using Greek letters. The initial practice of naming them according to where the variants were identified is no longer common. A more systematic naming scheme reflects the variant's pango lineage and is used for other variants. Epidemiology. Background. SARS-CoV-2 is a newly discovered virus that is closely related to bat coronaviruses, pangolin coronaviruses, and SARS-CoV. The first known outbreak started in Wuhan, Hubei, China, in November 2019. Many early cases were linked to people who had visited the Huanan seafood wholesale market there, but it is possible that human-to-human transmission began earlier. The scientific consensus is that the virus is most likely of a zoonotic origin, from bats, or another closely related mammal. Despite this, the subject has generated extensive speculation about alternative origins. The origin controversy heightened geopolitical divisions, notably between the United States and China. The earliest known infected person fell ill on December 1, 2019. That individual did not have a connection with the later wet market cluster. However, an earlier case may have occurred on November 17. Two-thirds of the initial case cluster were linked with the market. Molecular clock analysis suggests that the index case is likely to have been infected between mid-October and mid-November 2019. Cases. Official case counts refer to the number of people who have been tested for COVID-19 and whose test has been confirmed positive according to official protocols, whether or not they experienced symptomatic disease. Due to the effect of sampling bias, studies which obtain a more accurate number by extrapolating from a random sample have consistently found that total infections considerably exceed the reported case counts. Many countries, early on, had official policies to not test those with only mild symptoms. The strongest risk factors for severe illness are obesity, complications of diabetes, anxiety disorders, and the total number of conditions. In early 2020, a meta-analysis of self-reported cases in China by age indicated that a relatively low proportion of cases occurred in individuals under 20. It was not clear whether this was because young people were less likely to be infected, or less likely to develop symptoms and be tested. A retrospective cohort study in China found that children and adults were just as likely to be infected. Among more thorough studies, preliminary results from April 9, 2020 found that in Ganjult, the center of a major infection cluster in Germany, 15% of a population sample tested positive for antibodies. Screening for COVID-19 in pregnant women in New York City, and blood donors in the Netherlands, found rates of positive antibody tests that indicated more infections than reported. Seroprevalence-based estimates are conservative, as some studies show that persons with mild symptoms do not have detectable antibodies. Initial estimates of the basic reproduction number for COVID-19 in January 2020 were between 1.4 and 2.5, but a subsequent analysis claimed that it may be about 5.7. In December 2021, the number of cases continued to climb due to several factors, including new COVID-19 variants. As of that December 28, 282,790,822 individuals worldwide had been confirmed as infected. As of April 14, 2022, over 500 million cases were confirmed globally. Most cases are unconfirmed, with the Institute for Health Metrics and Evaluation estimating the true number of cases as of early 2022 to be in the billions. Deaths. As of November 9, 2022, more than 6.6 million deaths had been attributed to COVID-19. The first confirmed death was in Wuhan on January 9, 2020. These numbers vary by region and over time, influenced by testing volume, healthcare system quality, treatment options, government response, time since the initial outbreak, and population characteristics, such as age, sex, and overall health. Multiple measures are used to quantify mortality. Official death counts typically include people who died after testing positive. Such counts exclude deaths without a test. Conversely, deaths of people who died from underlying conditions following a positive test may be included. Countries such as Belgium include deaths from suspected cases, including those without a test, thereby increasing counts. Official death counts have been claimed to underreport the actual death toll, because excess mortality data show an increase in deaths that is not explained by COVID-19 deaths alone. Using such data, estimates of the true number of deaths from COVID-19 worldwide have included a range from 16.6 to 28.3 million by The Economist, as well as over 10.3 million by the Institute for Health Metrics and Evaluation, and 18.2 million deaths between January 1, 2020, and December 31, 2021 by a comprehensive international study. Such deaths include deaths due to healthcare capacity constraints and priorities, as well as reluctance to seek care. Further research may help distinguish the proportions directly caused by COVID-19 from those caused by indirect consequences of the pandemic. In May 2022, the WHO estimated the number of excess deaths to be 14.9 million compared to 5.4 million reported COVID-19 deaths, with the majority of the unreported 9.5 million deaths believed to be direct deaths due to the virus, rather than indirect deaths. Some deaths were because people with other conditions could not access medical services. The time between symptom onset and death ranges from 6 to 41 days, typically about 14 days. Mortality rates increase as a function of age. People at the greatest mortality risk are the elderly and those with underlying conditions. Infection fatality ratio. Case fatality ratio. Disease variants. Several variants have been named by WHO and labeled as a variant of concern or a variant of interest. They share the more infectious D614G mutation, Delta dominated and then eliminated earlier VOC from most jurisdictions. Omicron's immune escapability may allow it to spread via breakthrough infections, which in turn may allow it to coexist with Delta, which more often infects the unvaccinated. Signs and symptoms. Symptoms of COVID-19 are variable, ranging from mild symptoms to severe illness. Common symptoms include headache, loss of smell and taste, nasal congestion and runny nose, cough, muscle pain, sore throat, fever, diarrhea, and breathing difficulties. People with the same infection may have different symptoms, and their symptoms may change over time. 3 common clusters of symptoms have been identified: 1 respiratory symptom cluster with cough, sputum, shortness of breath, and fever, a musculoskeletal symptom cluster with muscle and joint pain, headache, and fatigue, a cluster of digestive symptoms with abdominal pain, vomiting, and diarrhea. In people without prior ear, nose, and throat disorders, loss of taste combined with loss of smell is associated with COVID-19 and is reported in as many as 88% of cases. Transmission. The disease is mainly transmitted via the respiratory route when people inhale droplets and small airborne particles that infected people exhale as they breathe, talk, cough, sneeze, or sing. Infected people are more likely to transmit COVID-19 when they are physically close. However, infection can occur over longer distances, particularly indoors. Cause. SARS-CoV-2 belongs to the broad family of viruses known as coronaviruses. It is a positive-sense single-stranded RNA virus, with a single linear RNA segment. Coronaviruses infect humans, other mammals, including livestock, and companion animals, and avian species. Human coronaviruses are capable of causing illnesses ranging from the common cold to more severe diseases such as Middle East respiratory syndrome. SARS-CoV-2 is the seventh known coronavirus to infect people, after 229E, NL63, OC43, HKU1, MERS-CoV, and the original SARS-CoV. Diagnosis. The standard methods of testing for presence of SARS-CoV-2 are nucleic acid tests, which detects the presence of viral RNA fragments. As these tests detect RNA but not infectious virus, its ability to determine duration of infectivity of patients is limited. The test is typically done on respiratory samples obtained by a nasopharyngeal swab. However, a nasal swab or sputum sample may also be used. The WHO has published several testing protocols for the disease. Prevention. Preventive measures to reduce the chances of infection include getting vaccinated, staying at home, wearing a mask in public, avoiding crowded places, keeping distance from others, ventilating indoor spaces, managing potential exposure durations, washing hands with soap and water often and for at least 20 seconds, practicing good respiratory hygiene, and avoiding touching the eyes, nose, or mouth with unwashed hands. Those diagnosed with COVID-19 or who believe they may be infected are advised by the CDC to stay home except to get medical care, call ahead before visiting a healthcare provider, wear a face mask before entering the healthcare provider's office and when in any room or vehicle with another person, cover coughs and sneezes with a tissue, regularly wash hands with soap and water and avoid sharing personal household items. Vaccines. Treatment. For the first 2 years of the pandemic, no specific and effective treatment or cure was available. In 2021, the European Medicines Agency's Committee for Medicinal Products for Human Use approved the oral antiviral protease inhibitor, Paxlovid, to treat adult patients. FDA later gave it an EUA. Most cases of COVID-19 are mild. In these, supportive care includes medication such as paracetamol or NSAIDs to relieve symptoms, adequate intake of oral fluids and rest. Good personal hygiene and a healthy diet are also recommended. Supportive care includes treatment to relieve symptoms, fluid therapy, oxygen support, and prone positioning, and medications or devices to support other affected vital organs. More severe cases may need treatment in hospital. In those with low oxygen levels, use of the glucocorticoid dexamethasone is recommended, to reduce mortality. Non-invasive ventilation and, ultimately, admission to an intensive care unit for mechanical ventilation may be required to support breathing. Extracorporeal membrane oxygenation has been used to address the issue of respiratory failure. Existing drugs such as hydroxychloroquine, lopinavir/ritonavir, ivermectin and so-called early treatment are not recommended by US or European health authorities, as there is no good evidence they have any useful effect. The antiviral remdesivir is available in the US, Canada, Australia, and several other countries, with varying restrictions. However, it is not recommended for use with mechanical ventilation, and is discouraged altogether by the World Health Organization, due to limited evidence of its efficacy. Prognosis. The severity of COVID-19 varies. The disease may take a mild course with few or no symptoms, resembling other common upper respiratory diseases such as the common cold. In 3–4% of cases symptoms are severe enough to cause hospitalization. Mild cases typically recover within 2 weeks, while those with severe or critical diseases may take 3 to 6 weeks to recover. Among those who have died, the time from symptom onset to death has ranged from 2 to 8 weeks. Prolonged prothrombin time and elevated C-reactive protein levels on admission to the hospital are associated with severe course of COVID-19 and with a transfer to intensive care units. Between 5% and 50% of COVID-19 patients experience long COVID, a condition characterized by long-term consequences persisting after the typical convalescence period of the disease. The most commonly reported clinical presentations are fatigue and memory problems, as well as malaise, headaches, shortness of breath, loss of smell, muscle weakness, low fever, and cognitive dysfunction. Strategies. Many countries attempted to slow or stop the spread of COVID-19 by recommending, mandating, or prohibiting behavior changes, while others relied primarily on providing information. Measures ranged from public advisories to stringent lockdowns. Outbreak control strategies are divided into elimination and mitigation. Experts differentiate between elimination strategies that aim to completely stop the spread of the virus within the community, and mitigation strategies that attempt to lessen the effects of the virus on society, but which still tolerate some level of transmission within the community. These initial strategies can be pursued sequentially or simultaneously during the acquired immunity phase through natural and vaccine-induced immunity. Nature reported in 2021 that 90% of immunologists who responded to a survey think that the coronavirus will become endemic. Containment. Containment is undertaken to stop an outbreak from spreading into the general population. Infected individuals are isolated while they are infectious. The people they have interacted with are contacted and isolated for long enough to ensure that they are either not infected or no longer contagious. Screening is the starting point for containment. Screening is done by checking for symptoms to identify infected individuals, who can then be isolated or offered treatment. The Zero COVID strategy involves using public health measures such as contact tracing, mass testing, border quarantine, lockdowns and mitigation software to stop community transmission of COVID-19 as soon as it is detected, with the goal of getting the area back to zero detected infections and resuming normal economic and social activities. Successful containment or suppression reduces RT to less than 1. Mitigation. Should containment fail, efforts focus on mitigation, measures taken to slow the spread and limit its effects on the healthcare system and society. Successful mitigation delays and decreases the epidemic peak, known as flattening the epidemic curve. This decreases the risk of overwhelming health services and provides more time for developing vaccines and treatments. Individual behavior changed in many jurisdictions. Many people worked from home instead of at their traditional workplaces. Non-pharmaceutical interventions. Other measures. Contact tracing. Healthcare. Who described increasing capacity and adapting healthcare as a fundamental mitigation. The ECDC and WHO's European Regional Office issued guidelines for hospitals and primary healthcare services for shifting resources at multiple levels, including focusing laboratory services towards testing, canceling elective procedures, separating and isolating patients, and increasing intensive care capabilities by training personnel and increasing ventilators and beds. The pandemic drove widespread adoption of telehealth. Improvised manufacturing. Herd immunity. In July 2021, several experts expressed concern that achieving herd immunity may not be possible because Delta can transmit among vaccinated individuals. CDC published data showing that vaccinated people could transmit Delta, something officials believed was less likely with other variants. Consequently, WHO and CDC encouraged vaccinated people to continue with non-pharmaceutical interventions such as masking, social distancing, and quarantining if exposed. In February 2022, the Icelandic Ministry of Health lifted all restrictions and adopted a herd immunity approach, and in June 2022 the Icelandic Ministry of Health's chief epidemiologist Rolfur Gunnarsson said that we have acquired a good herd immunity, because otherwise the situation would be much worse. History. 2019. The outbreak was discovered in Wuhan in November 2019. It is possible that human-to-human transmission was happening before the discovery. Based on a retrospective analysis starting from December 2019, the number of cases in Hubei gradually increased, reaching 60 by December 20 and at least 266 by 31 December. A pneumonia cluster was observed on December 26 and treated by Dr. Zhang Jixian. She informed the Wuhan Jianghan CDC on December 27. Vision Medicals reported the discovery of a novel coronavirus to the China CDC on 28 December. On December 30, a test report from Capital Biomed Lab addressed to Wuhan Central Hospital reported an erroneous positive result for SARS, causing doctors there to alert authorities. 8 of those doctors, including Li Wenliang, were later admonished by the police for spreading false rumors, and Ai Fen was reprimanded. That evening, Wuhan Municipal Health Commission issued a notice about the treatment of pneumonia of unknown cause. The next day, WMHC made the announcement public, confirming 27 cases enough to trigger an investigation. On December 31, the WHO office in China was informed of cases of the pneumonia cases and immediately launched an investigation. Official Chinese sources claimed that the early cases were mostly linked to the Huanan seafood wholesale market, which also sold live animals. However, in May 2020, CCDC Director George Gao indicated the market was not the origin. 2020. On January 11, WHO was notified by the Chinese National Health Commission that the outbreak was associated with exposures in the market, and that China had identified a new type of coronavirus, which it isolated on 7 January. Initially, the number of cases doubled approximately every 7.5 days. In early and mid-January, the virus spread to other Chinese provinces, helped by the Chinese New Year migration. Wuhan was a transport hub and major rail interchange. On January 10, the virus's genome was shared through Gizaid. A retrospective study published in March found that 6,174 people had reported symptoms by January 20. A January 24 report indicated human transmission, recommended personal protective equipment for health workers, and advocated testing, given the outbreak's pandemic potential. On January 31, the first published modeling study warned of inevitable independent self-sustaining outbreaks in major cities globally and called for large-scale public health interventions. On January 30, 7,818 infections had been confirmed, leading WHO to declare the outbreak a public health emergency of international concern. On March 11, WHO elevated it to a pandemic. By January 31, Italy had its first confirmed infections, in 2 tourists from China. On March 19, Italy overtook China as the country with the most reported deaths. By March 26, the United States had overtaken China and Italy as the country with the highest number of confirmed infections. Genomic analysis indicated that the majority of New York's confirmed infections came from Europe, rather than directly from Asia. Testing of prior samples revealed a person who was infected in France on December 27, 2019 and a person in the United States who died from the disease on February 6. In October, WHO reported that 1 in 10 people around the world may have been infected, or 780 million people, while only 35 million infections had been confirmed. On November 9, Pfizer released trial results for a candidate vaccine, showing a 90% effectiveness against infection. That day, Novavax entered an FDA fast-track application for their vaccine. On December 14, Public Health England reported that a variant had been discovered in the UK's southeast, predominantly in Kent. The variant, later named Alpha, showed changes to the spike protein that could be more infectious. As of December 13, 1,108 infections had been confirmed. On February 4, 2020, U.S. Secretary of Health and Human Services Alex Azar waived liability for vaccine manufacturers. 2021. On January 2, the Alpha variant, first discovered in the UK, had been identified in 33 countries. On January 6, the Gamma variant was first identified in Japanese travelers returning from Brazil. On January 29, it was reported that the Novavax vaccine was 49% effective against the Beta variant in a clinical trial in South Africa. The CoronaVac vaccine was reported to be 50.4% effective in a Brazil clinical trial. On March 12, several countries stopped using the Oxford-AstraZeneca COVID-19 vaccine due to blood clotting problems, specifically cerebral venous sinus thrombosis. On March 20, the WHO and European Medicines Agency found no link to thrombus, leading several countries to resume the vaccine. In March, WHO reported that an animal host was the most likely origin, without ruling out other possibilities. The Delta variant was first identified in India. In mid-April, the variant was first detected in the UK, and 2 months later it had metastasized into a third wave there, forcing the government to delay reopening that was originally scheduled for June. On November 10, Germany advised against the Moderna vaccine for people under 30. On November 24, the Omicron variant was detected in South Africa. A few days later, the World Health Organization declared it a VOC. The new variant is more infectious than the Delta variant. 2022. On January 1, Europe passed 100 million cases amidst a surge in the Omicron variant. Later that month, on January 14, the World Health Organization recommended 2 new treatments, baricitinib and sotrovimab. Later, on January 24, it was reported that about 57% of the world had been infected by COVID-19, per the Institute for Health Metrics and Evaluation Model. On March 6, it was reported that the total worldwide death count had surpassed 6 million people since the start of the pandemic. Sometime later, on July 6, it was reported that Omicron subvariants BA.4 and BA.5 had spread worldwide. On October 21, the United States surpassed 99 million cases of COVID-19, the most cases of any country. The first Northern Hemisphere autumn after the relaxation of U.S. public health measures led to a surge in respiratory viruses and co-infections in both adults and children. This formed the beginnings of the 2022 pediatric care crisis and what some experts have termed a tripledemic of seasonal influenza, respiratory syncytial virus, and SARS-CoV-2. On October 30, it was reported that worldwide 424 deaths occurred due to the virus, the lowest since 385 deaths were reported on March 12, 2020. November 17 will mark the 3-year anniversary since health officials in China first detected COVID-19. National responses. National reactions ranged from strict lockdowns to public education campaigns. WHO recommended that curfews and lockdowns should be short-term measures to reorganize, regroup, rebalance resources, and protect the healthcare system. As of March 26, 2020, 1.7 billion people worldwide were under some form of lockdown. This increased to 3.9 billion people by the first week of April, more than half the world's population. Asia. As of the end of 2021, Asia's peak had come at the same time and at the same level as the world as a whole, in May 2021. However, cumulatively they had experienced only half the world average. China opted for containment, inflicting strict lockdowns to eliminate spread. The vaccines distributed in China included the BIBP, WIBP, and CoronaVac. It was reported on December 11, 2021 that China had vaccinated 1.162 billion of its citizens, or 82.5% of the total population of the country against COVID-19. During the initial outbreak, multiple sources cast doubt upon the accuracy of China's death tolls, with some suggesting intentional data suppression. China's large-scale adoption of zero-COVID had largely contained the first wave of infections of the disease, with external experts agreeing with the accuracy of China's infection numbers and deaths since the initial outbreak. China is almost alone in pursuing a zero-COVID policy to combat the continuing wave of infections due to the Omicron variant in 2022. The first case in India was reported on January 30, 2020. India ordered a nationwide lockdown starting March 24, 2020, with a phased unlock beginning June 1, 2020. 6 cities accounted for around half of reported cases: Mumbai, Delhi, Ahmedabad, Chennai, Pune, and Kolkata. Post-lockdown, the Government of India introduced a contact tracking app called Arogya Setu to help authorities manage contact tracing. Later this app was also used for a vaccination management program. India's vaccination program was considered to be the world's largest and the most successful, with over 90% of citizens getting the first dose and another 65% getting the second dose. A second wave hit India in April 2021, straining healthcare services. On October 21, 2021, it was reported that the country had surpassed 1 billion vaccinations. Iran reported its first confirmed cases on February 19, 2020 in Qom. Early measures included the cancellation of concerts and other cultural events, Friday prayers, and education shutdowns. Iran became a center of the pandemic in February 2020. More than 10 countries had traced their outbreaks to Iran by February 28, indicating a more severe outbreak than the 388 reported cases. The Iranian parliament closed, after 23 of its 290 members tested positive on March 3, 2020. At least 12 sitting or former Iranian politicians and government officials had died by March 17, 2020. By August 2021, the pandemic's fifth wave peaked, with more than 400 deaths in one day. COVID-19 was confirmed in South Korea on January 20, 2020. Military bases were quarantined after tests showed 3 infected soldiers. South Korea introduced what was then considered the world's largest and best organized screening program, isolating infected people, and tracing and quarantining contacts. Screening methods included mandatory self-reporting by new international arrivals through mobile application, combined with drive-through testing, and increasing testing capability to 20,000 people/day. Despite some early criticisms, South Korea's program was considered a success in controlling the outbreak without quarantining entire cities. Europe. The global COVID-19 pandemic arrived in Europe with its first confirmed case in Bordeaux, France, on January 24, 2020, and subsequently spread widely across the continent. By March 17, 2020, every country in Europe had confirmed a case, and all have reported at least one death, with the exception of Vatican City. Italy was the first European nation to experience a major outbreak in early 2020, becoming the first country worldwide to introduce a national lockdown. By March 13, 2020, the World Health Organization declared Europe the epicenter of the pandemic, and it remained so until the WHO announced it had been overtaken by South America on May 22. By March 18, 2020, more than 250 million people were in lockdown in Europe. Despite deployment of COVID-19 vaccines, Europe became the pandemic's epicenter once again in late 2021. The Italian outbreak began on January 31, 2020, when 2 Chinese tourists tested positive for SARS-CoV-2 in Rome. Cases began to rise sharply, which prompted the government to suspend flights to and from China and declare a state of emergency. On February 22, 2020, the Council of Ministers announced a new decree law to contain the outbreak, including quarantining more than 50,000 people in northern Italy. On March 4, the Italian government ordered schools and universities closed as Italy reached 100 deaths. Sport was suspended completely for at least 1 month. On March 11, Conte stopped nearly all commercial activity except supermarkets and pharmacies. On March 19, Italy overtook China as the country with the most COVID-19 related deaths. On April 19 the first wave ebbed, as 7-day deaths declined to 433. On October 13, the Italian government again issued restrictive rules to contain the second wave. On November 10 Italy surpassed 1 million confirmed infections. On November 23, it was reported that the second wave of the virus had led some hospitals to stop accepting patients. The virus was first confirmed to have spread to Spain on January 31, 2020, when a German tourist tested positive for SARS-CoV-2 in La Gomera, Canary Islands. Post-hoc genetic analysis has shown that at least 15 strains of the virus had been imported, and community transmission began by mid-February. On March 29, it was announced that, beginning the following day, all non-essential workers were ordered to remain at home for the next 14 days. The number of cases increased again in July in a number of cities including Barcelona, Zaragoza, and Madrid, which led to reimposition of some restrictions but no national lockdown. By September 2021, Spain was one of the countries with the highest percentage of its population vaccinated, while also being one of the countries more in favor of vaccines against COVID-19. However, as of January 21, 2022, this figure had only increased to 80.6%. Nevertheless, Spain leads Europe for per capita full vaccination rates. Italy is ranked second at 75%. Sweden differed from most other European countries in that it mostly remained open. Per the Swedish constitution, the Public Health Agency of Sweden has autonomy that prevents political interference, and the agency favored remaining open. The Swedish strategy focused on longer-term measures, based on the assumption that after lockdown the virus would resume spreading, with the same result. By the end of June, Sweden no longer had excess mortality. Devolution in the United Kingdom meant that each of its 4 countries developed its own response. England's restrictions were shorter-lived than the others. The UK government started enforcing social distancing and quarantine measures on March 18, 2020. On March 16, Prime Minister Boris Johnson advised against non-essential travel and social contact, praising work from home and avoiding venues such as pubs, restaurants, and theaters. On March 20, the government ordered all leisure establishments to close, and promised to prevent unemployment. On March 23, Johnson banned gatherings and restricted non-essential travel and outdoor activity. Unlike previous measures, these restrictions were enforceable by police through fines and dispersal of gatherings. Most non-essential businesses were ordered to close. On April 24, 2020, it was reported that a promising vaccine trial had begun in England. The government pledged more than £50 million towards research. On April 16, 2020, it was reported that the UK would have first access to the Oxford vaccine, due to a prior contract. Should the trial be successful, some 30 million doses would be available. On December 2, 2020, the UK became the first developed country to approve the Pfizer vaccine. 800,000 doses were immediately available for use. North America. The virus arrived in the United States on January 13, 2020. Cases were reported in all North American countries after St. Kitts and Nevis confirmed a case on March 25, and in all North American territories after Bonaire confirmed a case on April 16. 97,900,497 confirmed cases have been reported in the United States with 1,073,932 deaths, the most of any country, and the 19th highest per capita worldwide. COVID-19 is the deadliest pandemic in U.S. history. It was the third leading cause of death in the U.S. in 2020, behind heart disease and cancer. From 2019 to 2020, U.S. life expectancy dropped by 3 years for Hispanic Americans, 2.9 years for African Americans, and 1.2 years for white Americans. These effects have persisted as U.S. deaths due to COVID-19 in 2021 exceeded those in 2020. In the United States, COVID-19 vaccines became available in December 2020, under emergency use, beginning the National Vaccination Program, with the first vaccine officially approved by the Food and Drug Administration on August 23, 2021. In March 2020, as cases of community transmission were confirmed across Canada, all of its provinces and territories declared states of emergency. Provinces and territories have, to varying degrees, implemented school and daycare closures, prohibitions on gatherings, closures of non-essential businesses and restrictions on entry. Canada severely restricted its border access, barring travelers from all countries with some exceptions. Cases surged across Canada, notably in the provinces of British Columbia, Alberta, Quebec, and Ontario, with the formation of the Atlantic Bubble, a travel-restricted area of the country. Vaccine passports were adopted in all provinces and 2 of the territories. South America. The COVID-19 pandemic was confirmed to have reached South America on February 26, 2020 when Brazil confirmed a case in São Paulo. By April 3, all countries and territories in South America had recorded at least 1 case. On May 13, 2020, it was reported that Latin America and the Caribbean had reported over 400,000 cases of COVID-19 infection with 23,091 deaths. On May 22, 2020, citing the rapid increase of infections in Brazil, the World Health Organization declared South America the epicenter of the pandemic. As of July 16, 2021, South America had recorded 34,359,631 confirmed cases and 1,047,229 deaths from COVID-19. Due to a shortage of testing and medical facilities, it is believed that the outbreak is far larger than the official numbers show. The virus was confirmed to have spread to Brazil on February 25, 2020, when a man from São Paulo who had traveled to Italy tested positive for the virus. The disease had spread to every federative unit of Brazil by March 21. On June 19, 2020, the country reported its 1 millionth case and nearly 49,000 reported deaths. One estimate of underreporting was 22.62% of total reported COVID-19 mortality in 2020. As of November 10, 2022, Brazil, with 34,855,492 confirmed cases and 688,395 deaths, has the third highest number of confirmed cases and second highest death toll from COVID-19 in the world, behind only those of the United States and of India. Africa. The COVID-19 pandemic was confirmed to have spread to Africa on February 14, 2020, with the first confirmed case announced in Egypt. The first confirmed case in sub-Saharan Africa was announced in Nigeria at the end of February 2020. Within 3 months, the virus had spread throughout the continent, as Lesotho, the last African sovereign state to have remained free of the virus, reported a case on May 13, 2020. By May 26, it appeared that most African countries were experiencing community transmission, although testing capacity was limited. Most of the identified imported cases arrived from Europe and the United States rather than from China where the virus originated. Many preventive measures have been implemented by different countries in Africa, including travel restrictions, flight cancellations, and event cancellations. In early June 2021, Africa faced a third wave of COVID infections with cases rising in 14 countries. By July 4 the continent recorded more than 251,000 new COVID cases, a 20% increase from the prior week and a 12% increase from the January peak. More than 16 African countries, including Malawi and Senegal, recorded an uptick in new cases. The World Health Organization labeled it Africa's worst pandemic week ever. In October 2022, it was reported by the World Health Organization that most countries on the African continent will miss the goal of 70% of their population being vaccinated by the end of 2022. Oceania. The COVID-19 pandemic was confirmed to have reached Oceania on January 25, 2020, with the first confirmed case reported in Melbourne, Australia. It has since spread elsewhere in the region. Australia and New Zealand were praised for their handling of the pandemic in comparison to other Western nations, with New Zealand and each state in Australia wiping out all community transmission of the virus several times even after reintroduction into the community. As a result of the high transmissibility of the Delta variant, however, by August 2021, the Australian states of New South Wales and Victoria had conceded defeat in their eradication efforts. In early October 2021, New Zealand also abandoned its elimination strategy. In November and December, following vaccination efforts, the remaining states of Australia, excluding Western Australia, voluntarily gave up COVID-0 to open up state and international borders. The open borders allowed the Omicron variant of COVID-19 to enter quickly, and cases subsequently exceeded 120,000 a day. By early March, with cases exceeding 1,000 a day, Western Australia conceded defeat in its eradication strategy and opened the borders after previously delaying the reopening due to the Omicron variant. Despite record cases, Australian jurisdictions slowly removed restrictions such as close contact isolation, mask wearing and density limits by April. On September 9, restrictions were significantly relaxed. The mask mandate on aircraft was scrapped nationwide. September 9 was also the last day cases were reported daily in Australia as the country transitioned to weekly reporting instead. On September 14, COVID-19 disaster payment for people who had to isolate due to COVID-19 was extended so long as isolating was mandated by the government. By September 22, all states had ended mask mandates on public transport, including in Victoria where the mandate had lasted some 800 days. On September 30, all Australian leaders declared the emergency response finished and announced the end of the requirement for people to isolate from October 14 if they have COVID-19, due in part to high levels of hybrid immunity and very low case numbers. Antarctica. Due to its remoteness and sparse population, Antarctica was the last continent to have confirmed cases of COVID-19 and was one of the last regions of the world affected directly by the pandemic. The first cases were reported in December 2020, almost a year after the first cases of COVID-19 were detected in China. At least 36 people are confirmed to have been infected. Other responses. The pandemic shook the world's economy, with especially severe economic damage in the United States, Europe, and Latin America. A consensus report by American intelligence agencies in April 2021 concluded, efforts to contain and manage the virus have reinforced nationalist trends globally, as some states turned inward to protect their citizens and sometimes cast blame on marginalized groups. COVID-19 inflamed partisanship and polarization around the world as bitter arguments exploded over how to respond. International trade was disrupted amid the formation of no-entry enclaves. Travel restrictions. The pandemic led many countries and regions to impose quarantines, entry bans, or other restrictions, either for citizens, recent travelers to affected areas, or for all travelers. Travel collapsed worldwide, damaging the travel sector. The effectiveness of travel restrictions was questioned as the virus spread across the world. One study found that travel restrictions only modestly affected the initial spread, unless combined with other infection prevention and control measures. Researchers concluded that travel restrictions are most useful in the early and late phase of an epidemic, and restrictions of travel from Wuhan unfortunately came too late. The European Union rejected the idea of suspending the Schengen free travel zone. Repatriation of foreign citizens. Several countries repatriated their citizens and diplomatic staff from Wuhan and surroundings, primarily through charter flights. Canada, the United States, Japan, India, Sri Lanka, Australia, France, Argentina, Germany, and Thailand were among the first to do so. Brazil and New Zealand evacuated their own nationals and others. On March 14, South Africa repatriated 112 South Africans who tested negative, while 4 who showed symptoms were left behind. Pakistan declined to evacuate its citizens. On February 15, the U.S. announced it would evacuate Americans aboard the Diamond Princess cruise ship, and on February 21, Canada evacuated 129 Canadians from the ship. In early March, the Indian government began repatriating its citizens from Iran. On March 20, the United States began to withdraw some troops from Iraq. United Nations. In June 2020, the Secretary-General of the United Nations launched the UN Comprehensive Response to COVID-19. The United Nations Conference on Trade and Development was criticized for its slow response, especially regarding the UN's global ceasefire, which aimed to open up humanitarian access to conflict zones. WHO. Protests against governmental measures. In several countries, protests rose against restrictions such as lockdowns. A February 2021 study found that protests against restrictions were likely to directly increase spread. Impact. Economics. The pandemic and responses to it damaged the global economy. On February 27, 2020, worries about the outbreak crushed U.S. stock indexes, which posted their sharpest falls since 2008. Tourism collapsed due to travel restrictions, closing of public places including travel attractions, and advice of governments against travel. Airlines cancelled flights, while British regional airline Flybe collapsed. The cruise line industry was hard hit, and train stations and ferry ports closed. International mail stopped or was delayed. The retail sector faced reductions in store hours or closures. Retailers in Europe and Latin America faced traffic declines of 40%. North America and Middle East retailers saw a 50–60% drop. Shopping centers faced a 33–43% drop in foot traffic in March compared to February. Mall operators around the world coped by increasing sanitation, installing thermal scanners to check the temperature of shoppers, and canceling events. Hundreds of millions of jobs were lost, including more than 40 million Americans. According to a report by Yelp, about 60% of U.S. businesses that closed will stay shut permanently. The International Labour Organization reported that the income generated in the first 9 months of 2020 from work across the world dropped by 10.7%, or $3.5 trillion. Supply shortages. Culture. The performing arts and cultural heritage sectors have been profoundly affected by the pandemic, impacting organizations' operations as well as individuals both employed and independent globally. By March 2020, across the world and to varying degrees, museums, libraries, performance venues, and other cultural institutions had been indefinitely closed with their exhibitions, events and performances cancelled or postponed. A UNESCO report estimated 10 million job losses worldwide in the culture and creative industries. Some services continued through digital platforms, such as live streaming concerts or web-based arts festivals. Politics. The pandemic affected political systems, causing suspensions of legislative activities, isolations, or deaths of politicians, and rescheduled elections. Although they developed broad support among epidemiologists, NPIs were controversial in many countries. Intellectual opposition came primarily from other fields, along with heterodox epidemiologists. On March 23, 2020, United Nations Secretary-General Antonio Manuel de Oliveira Guterres appealed for a global ceasefire. 172 UN member states and observers signed a non-binding supporting statement in June, and the UN Security Council passed a resolution supporting it in July. China, Italy, United States. Other countries. Food systems. The pandemic disrupted food systems worldwide, hitting at a time when hunger and undernourishment were rising. Food access fell, driven by falling incomes, lost remittances, and disruptions to food production. In some cases, food prices rose. The pandemic and its accompanying lockdowns and travel restrictions slowed movement of food aid. Per the World Health Organization, 811 million individuals were undernourished in 2020, likely related to the fallout of COVID-19. Education. The pandemic impacted educational systems in many countries. Many governments temporarily closed educational institutions, often replaced by online education. Other countries, such as Sweden, kept their schools open. As of September 2020, approximately 1.077 billion learners were affected due to school closures. School closures impacted students, teachers, and families with far-reaching economic and societal consequences. They shed light on social and economic issues, including student debt, digital learning, food insecurity, and homelessness, as well as access to childcare, healthcare, housing, internet, and disability services. The impact was more severe for disadvantaged children. The Higher Education Policy Institute reported that around 63% of students claimed worsened mental health as a result of the pandemic. Health. The pandemic impacted global health for many other conditions. Hospital visits fell. Visits for heart attack symptoms declined by 38% in the US and 40% in Spain. The head of cardiology at the University of Arizona said, "My worry is some of these people are dying at home because they're too scared to go to the hospital." People with strokes and appendicitis were less likely to seek treatment. Medical supply shortages impacted many people. The pandemic impacted mental health, increasing anxiety, depression, and post-traumatic stress disorder, affecting healthcare workers, patients, and quarantined individuals. Environment. The pandemic and the reaction to it positively affected the environment and climate as a result of reduced human activity. During the Anthropocene, fossil fuel use decreased, resource consumption declined, and waste disposal improved, generating less pollution. Planned air travel and vehicle transportation declined. In China, lockdowns and other measures resulted in a 26% decrease in coal consumption, and a 50% reduction in nitrogen oxides emissions. Earth Systems scientist Marshall Burke estimated that 2 months of pollution reduction likely saved the lives of 53,000 to 77,000 Chinese residents. A wide variety of largely mammalian species, both captive and wild, have been shown to be susceptible to SARS-CoV-2, with some encountering particularly fatal outcomes. In particular, both farmed and wild mink have developed symptomatic COVID-19 infections, leading to a 35–55% mortality rate in one study. Other animals, such as white-tailed deer, have not exhibited as high mortality numbers but have effectively become natural reservoirs of the virus, with large numbers of free-ranging deer infected throughout the US and Canada, including approximately 80% of Iowa's wild deer herd. Discrimination and prejudice. Heightened prejudice, xenophobia, and racism toward people of Chinese and East Asian descent were documented around the world. Reports from February 2020 cited racist sentiments about Chinese people deserving the virus. Chinese people and other Asian peoples in the United Kingdom and United States reported increasing levels of abuse and assaults. Former U.S. President Trump was criticized for referring to SARS-CoV-2 as the Chinese virus and Kung flu, which others condemned as racist and xenophobic. Age-based discrimination against older adults increased. This was attributed to their perceived vulnerability and subsequent physical and social isolation measures, which, coupled with their reduced social activity, increased dependency on others. Similarly, limited digital literacy left the elderly more vulnerable to isolation, depression, and loneliness. Correspondence published in The Lancet on November 20, 2021 suggested the inappropriate stigmatization of unvaccinated people, who include our patients, colleagues, and other fellow citizens, noting vaccinated individuals' high rates of infection, high viral loads, and therefore their relevant role in transmission. In January 2022, Amnesty International urged Italy to change their anti-COVID-19 restrictions to avoid discrimination against unvaccinated people, saying that the government must continue to ensure that the entire population can enjoy its fundamental rights. The restrictions included mandatory vaccination over the age of 50, and mandatory vaccination in order to use public transport. Lifestyle changes. The pandemic triggered massive changes in behavior, from increased internet commerce to cultural changes in the job market. Online retailers in the U.S. posted $791.70 billion in sales in 2020, an increase of 32.4% from $598.02 billion from the year before. Home delivery orders increased, while indoor restaurant dining shut down due to lockdown orders or low sales. Hackers, cybercriminals, and scammers took advantage of the changes to launch new attacks. Education in some countries temporarily shifted from physical attendance to video conferencing. Massive layoffs shrank the airline, travel, hospitality, and other industries. Despite most corporations implementing measures to address COVID-19 in the workplace, a poll from Catalyst found that as many as 68% of employees around the world felt that these policies were only performative and not genuine. Historiography. A 2021 study noted that the COVID-19 pandemic had increased interest in epidemics and infectious diseases among both historians and the general public. Prior to the pandemic, these topics were usually overlooked by general history and only received attention in the history of medicine. Information dissemination. Some news organizations removed their online paywalls for some or all of their pandemic-related articles and posts. Some scientific publishers made pandemic-related papers available with open access. The share of papers published on preprint servers prior to peer review increased dramatically. Research is indexed and searchable in the NIH COVID-19 portfolio. Misinformation. Misinformation and conspiracy theories about the pandemic are widespread. They traveled through mass media, social media, and text messaging. Who declared an infodemic of incorrect information? Cognitive biases, such as jumping to conclusions and confirmation bias, were linked to conspiracy beliefs, including COVID-19 vaccine hesitancy. Transition to endemic phase. While the COVID-19 pandemic is still considered ongoing by the World Health Organization, Ghebreyesus of the WHO stated on September 14, 2022 that never been in a better position to end the pandemic, citing the lowest number of weekly reported deaths since March 2020. He continued, "We are not there yet. But the end is in sight, we can see the finish line." In June 2022, an article in Human Genomics said that the pandemic was still raging, but that now is the time to explore the transition from the pandemic to the endemic phase. The latter will require worldwide vigilance and cooperation, especially in emerging countries, and suggested that developed countries should assist in boosting vaccination rates worldwide. As of November 4, 2022, the following countries have declared the COVID-19 virus endemic or have begun transitioning to an endemic phase: Indonesia, Mexico, Philippines, South Korea, Spain, Vietnam. Culture and society. The COVID-19 pandemic in popular culture has been depicted in a variety of digital mediums. Films. South Park, Post-COVID, 2021 animated comedy film regarding the main characters of South Park series such as Stan Marsh being forced to deal with the new realities of post-COVID-19 40 years later. Songbird, 2020, science fiction thriller film that is inspired by the COVID-19 pandemic with an exaggerated twist of COVID-19 mutating to COVID-23 in the year 2024. Television. Grey's Anatomy, a 2005 series about the life of Dr. Meredith Grey and other doctors, allowed in season 17 to focus on the life during and after the COVID-19 pandemic. Queen Sugar, a 2016 drama series is about some siblings who are forced to cope with their new life of taking over the sugarcane farm after a loved one's death. In Season 6 the story is predominantly about the COVID-19 pandemic and some of the characters catching COVID such as Charlie. See also: Emerging infectious disease, globalization and disease, list of epidemics, coronavirus diseases. Notes. References. Further reading. External links.